Thank you, Vedra, and thank you, Garth, and it's really an honor and privilege to be here. I'm going to try to talk to you today about and really try to make a strong case for the use of mesh to prevent incisional hernia repairs, so we're switching gears a little bit. I got this invitation from Vedra and Garth, and I was initially going to debate a gentleman who's a giant in hernia surgery, Robert Ben David, and very outspoken against mesh, and I was pretty scared, and then they invited a lawyer instead to debate me, so a professional arguer, so I'm kind of at a loss here, but I'll try to do my best. I do have some disclosures. I do work with several mesh companies. I'm on the scientific board of two companies, one that makes mesh and one that makes a mesh suture, and I do receive some royalties from a textbook of hernia that I help edit. So we know this is a great patriot from the United States who said this many years ago. Should we be preventing things? And this is not new. Prevention is not new to us as physicians. We all, there's a lot of debate about vaccines, but we all think that vaccines work. Obviously, birth control. We all go to the dentist several times a year to get our teeth cleaned. And really, as surgeons, we do some prophylaxis as well. Prophylactic mastectomy in the right person is well accepted. We all give antibiotics before a surgery. Sometimes in patients at high risk for colon cancer, we'll do colectomies, and a lot of us put ureteral stents in. These are all ways that we try to prevent problems. And the problem here is incisional hernia. And I think Gina mentioned this earlier, but this is a major problem in the United States and globally for healthcare. It costs a lot of money, as Todd showed you, and I'm going to try to show you too. This is a bad problem, and I don't mean to sound bad about this, but we're not good at fixing hernias. I mean, we just have to face facts. There may be probably a lot of you in the audience are good at fixing hernias, but as a general surgery group globally, we're not good at fixing hernias, and I'm going to show you some of these data. Well, I always love being at SAGES because you guys are the people who are trying to prevent incisional hernias by doing things minimally invasively, robotically. You're trying not to do laparotomies, and that's great, but there's still a lot of laparotomies that are being done in the United States. You can see this, and you can see this is some John Fisher's work, but it still shows that we're discharging a lot of people with incisional hernias. It's not going away. People are still doing a lot of laparotomies. This is the most quoted study in the hernia literature, and I know you've seen it 1,000 times. I put a little bit different spin on it, and my spin from this is not that mesh is good for fixing hernias. It is. I mean, one of the few truths I think we have in hernias is mesh reduces hernia recurrence. But what I want to show you is without mesh, the hernia recurrence rate was 2/3, 63% of patients. That's horrible. With mesh, we're not that much better. 1 in 3 patients will develop a hernia in this study. Long-term follow-up, really good data, randomized control trial from this. A lot of people say, well, that's European data, it's old data. Well, David Flum did the same thing. It's not quite as high here, but he shows that 23 patients, long-term follow-up, this is a population-based study, will have a recurrence, even with the use of mesh, and they're going to go on to have an operation, and Todd showed this earlier. I think this is really good. If we don't think we're fixing hernias well the first time, we really are bad at fixing hernias the second, third, fourth time. I mean, we just have disastrous results. This vicious cycle, I think, is real. A lot of it's due to infection, a lot of it's due to complex cases, but whatever the reason is, it gets harder to fix these hernias. And so most of us have focused, and I think rightly so, on trying to improve our techniques. You've seen a lot of great talks, how you can do better, how we can use a better mesh, sort of this right side of this curve. But I think if we're going to look at this entire picture, we need to start looking at how we're making incisional hernias and how we can reduce that. And prophylactic mesh is really one of the answers of how we can do this. I think you're familiar with this as basically just placing a piece of mesh at the index surgery, and we can talk about some of the nuances where you place the mesh and things like that, but it's basically placing a mesh to try to prevent an incisional hernia. And so, again, I think the key on this, and Archana kind of mentioned it, peristoma is a little bit different. The key for laparotomy or trying to prevent an incisional hernia is picking the right patients. And John Fisher did a great study. This was published in the Annals of Surgery, and really nice job of showing that we can really predict pretty well who's going to develop an incisional hernia. And I think most of you guys know this. It's obese patients. There's a lot of things, but he showed that we can predict this. Not only can we predict it, but we're going to predict when they're going to have it. Todd showed some of this. Early patients develop hernias fairly quickly. And so what do you do? One of the most widely patients that looked at this is abdominal aortic aneurysms. I know we don't do a lot of open abdominal aortic aneurysms anymore, but this is a great study by Philip Meisums here, and a randomized controlled trial. These high-risk patients for developing incisional hernias, we know that based on some biology, and he showed at 2-year follow-up, if he just sutured this, 28% would get an incisional hernia, and he swears by these numbers. I always get worried when I see a 0 in a study, but 0% in the patients that underwent prophylactic mesh. Yes, it took a little bit longer, but importantly, none of these patients had mesh-related complications. And so, very impactful study. This was a great study by Hans Jekyll. Again, he kind of corroborated the evidence by Philip. He looked at abdominal aortic aneurysms. The great part about this study, this was published in the Lancet, and I think the really important thing for those who are interested in prophylactic mesh is Dr. Meisums did this study with a retrorectus synthetic polypropylene mesh. A lot of hernia surgeons very comfortable with that, but if you start talking about extending this out to colorectal surgeons, vascular surgeons, all these other folks, having them do a retrorectus repair is going to be very difficult. So in this study, they compared the difference between a retrorectus and an onlay mesh with glue. And importantly, they showed that the onlay mesh did just as well as a retrorectus mesh and perhaps even better. So I think it gives us some idea that we probably can help prevent incisional hernias by doing an onlay mesh. This is a meta-analysis. I agree with Archana. There have been a lot of meta-analysis lately on prophylactic mesh. This is one John Fisher and I did recently. It was on 14 studies. Over 2,000 patients here with over 1,000 receiving prophylactic mesh. And I'm going to go through some of the data here. And there's no doubt, it's fairly clear in these studies that if you use mesh prophylactically, it will reduce the rate of incisional hernia. It's very clear. And then there's a question of where do you put the mesh? And I think it basically shows here, no matter where you put the mesh, it's going to decrease the chance of incisional hernia. So if you onlay the mesh, it was clearly significant. If you do a retrorectus repair, or if you do a preperitoneal mesh, all of these resulted in a decrease incisional hernia rate compared to primary suture. It's not perfect, and so I think we need to be clear here, and I'm sure this will come up. The seroma rate was higher by placing a prophylactic mesh than just a suture repair. And I think this is fairly clear to folks. If you're making a subcutaneous pocket to place the mesh, you're probably going to have a higher seroma rate. And then I think this is one that's definitely going to need some more study, and especially with the climate, medical legal climate in the United States right now. What about chronic pain? And so we're going to have issues down the road with placing a lot of prophylactic mesh. And I think that's something that needs to be looked at and probably discussed, and for sure discussed with your patient. We don't know now, but the studies right now show that the chronic pain overall is higher with the prophylactic mesh. And so the European Hernia Society, in their guidelines, these are several years old, basically said that we think prophylactic mesh is good, but we need more studies to really make a strong recommendation for this. And then I always get asked about the economics of this, and nobody's going to pay for this. We don't get paid for this as surgeons, and I think there's some things that surely are not in the favor of the surgeons right now placing this economically. But if you look at this from a global or healthcare society perspective, number one, there was a study in 2013 showing basically hernia repairs can lose money fixing hernia repairs. Obviously, this depends a lot on your mesh choice. And then if you look at John Fisher's data on multi-center cost analysis, he showed that if you reduce the recurrence rate of incisional hernias just by 1%, that would save us $32 million. And then a prophylactic mesh could be as high as almost $4,000 and still be cost effective at the time of hernia prevention. And then a similar study done in France showed that if they could reduce their incisional hernia rate by 5%, they would save 4 million euros. So I think there is some benefit to our community and our global economy if we can decrease this. So in summary, I think we all know incisional hernias are a problem. They're costly. They're difficult to fix. There is still a lot of open surgery being done. And we surely can predict some people that are going to be at risk. There's no doubt that prophylactic mesh decreases the chance of developing incisional hernia, and I think is cost effective in the long run. I do think this needs to be targeted to the right people, and we still don't know which technique, which mesh, who should perform this, and obviously we need to follow the long-term outcomes. So thank you very much.